We want to be respectful of time, so we're going to get underway. On behalf of Queen's University, it's my pleasure to welcome you here to the 25th Duncan G. Sinclair Lectureship in Health Services and Policy Research. So the 25th, it's a big milestone for us. Before we start, I want to take a moment to acknowledge that we're situated here on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. This is a place, Cataraqui, where peoples used to come together on an annual basis to hunt and to fish and to talk and to share thoughts. And that is really what we're doing here today. Maybe not so much hunting and fishing, but certainly sharing thoughts and sharing ideas, exchanging knowledge, and hopefully enriching everybody who is participating in this event, both here in person and those of you that happen to be online with our live stream. My name is Warren Mabey, and I'm the director of the School of Policy Studies, so it's again my pleasure to welcome you here and to say a few words about the Duncan Sinclair Lectureship. As I said, it is the 25th edition, and it is named after Dr. Duncan Sinclair. Those of you who are in our symposium today had the pleasure of hearing from him directly. He took part in one of our panels, and it's a testament to his dedication and his involvement that he remains engaged in university life, despite the fact that he has been doing this for decades, and if anyone deserves a rest, it is probably Duncan. Duncan served as the Dean of the Faculty of Arts and Science in the 1970s and early 1980s. He held a number of senior leadership roles at Queen's University, but one of the things that he did was he was seconded to work with what was then called the Medical Research Council. And in his work, he was the Director General of Program Operations with that council. And in recognition of his contributions, the Medical Research Council actually made the first donations to set up this lectureship. The Sinclair family has since then generously built on that, and so we have enjoyed many, many prominent speakers over the years. It's something that I think we all look forward to every year, and we're very grateful to both the council that helped to establish this and to the Sinclair family for supporting it and ensuring that it will be a long-lasting and a big impact series of talks. I will also say that Duncan is a little bit of a personal hero of mine. Anybody who can contribute as much as he has to the administration of the university and still be a top-notch researcher who is leading thinking in his area up to today really is somebody that I admire and I would aspire to be. So I really wanted to say that and to get that across. I'm going to ask Catherine Donnelly to come up and to introduce our speaker for today, so please join me in welcoming her.
Thanks, Warren. As Warren mentioned, my name is Catherine Donnelly. I'm the director of the Health Services and Policy Research Institute, and it is really my great privilege to be able to introduce Dr. Chris Simpson today, the 2022 Sinclair Lecturer. Dr. Simpson is currently the Executive Vice President and Chief Medical Officer at Ontario Health, the agency that oversees healthcare in Ontario, no small feat. Dr. Simpson has deep roots here in Kingston. At Queen's, he is a professor in the Department of Medicine and School of Policy Studies and has served as the head of cardiology, vice dean of the Faculty of Health Sciences, as it was named at the time, and the medical director of the Southeastern Ontario Academic Medical Organization, CMO. At KHSC, he was the head of the cardiac programs and continues to practice as a cardiologist. While Kingston has benefited enormously, Dr. Simpson has also contributed far more broadly. He was the 147th president of the Canadian Medical Association, where he focused his attention on aging and specifically advocating for more comprehensive and integrated care for older adults as a foundation for improving the Canadian healthcare system. Looking back, this feels prescient. From 2020 to 2021, Dr. Simpson was president of the Canadian Academy of Health Sciences. On top of all that, he has received numerous awards and recognition for his clinical work, outstanding clinician, and for his leadership and influence, being named twice by the Medical Post as one of Canada's most influential physicians. On top of his leadership roles, he is an impressive researcher. He is an affiliate scientist at ICS, cited over 8,000 times. His health services research explores access to care and medical wait times, health human resources, and care for older adults. If that wasn't enough, however, he even has his own Wikipedia page, so I was most impressed. Please welcome Dr. Chris Simpson.
Well, thanks, Catherine, and thanks everybody for being here, and wanted to reach out as well to everybody online who's joined. I think this is a new way of doing business, being able to view from a distance, and certainly I know that I've done a lot of my CME and ongoing work remotely, and it certainly has its advantages, but I have to say it's really nice to see everybody in person, and I've really enjoyed the day here today so far. I also have to say, to be given the honor of delivering the Sinclair Lecture, named for somebody who's been a very generous mentor to me for about 30 years, is a very distinct honor. And Duncan, as you all know, is a very, very special guy, and I love the way that he's able to take very complex ideas and distill them to a piece of wisdom that always comes back into my head and has come into my head many times as I'm trying to tackle difficult problems. And the thing that I'm thinking about most today that Duncan always says is our so-called healthcare system, as he often says, meaning, of course, that we really don't have a system at all. So I wanted to wander through a little bit of an introduction about Ontario Health, and then really focus on, I think, some themes that were brought up earlier today around taking advantage of all of this disruption and trying to turn it into an opportunity. So I want to be a bit of a combination of the first three speakers who really nicely laid out some of the problems that we're facing, but bring in a little bit of Dr. Philpott's optimism around some things that I think are happening, and most importantly, what is going to be our big opportunities for the future. So I do remain first and foremost a clinician. As the introduction indicated, I'm a cardiologist here at Queen's, but I've taken on this new role at Ontario Health, that of the Chief Medical Officer and Executive Vice President. And so I wanted to give you a bit of an explanation of what Ontario Health actually is. It is a relatively new creation. It was originally called the Super Agency, I think, before it was named. Came into being in 2019 and brought together 21 legacy agencies as well as all of the old local health integration networks, the LHINs. Coming into OH were the old Cancer Care Ontario, Core Health, which was the agency overseeing cardiac, stroke, and vascular care, Trillium Gift of Life, which was our transplant agency, the Ontario Renal Network, Health Quality Ontario, the Ontario Telemedicine Network, eHealth Ontario, Health Force Ontario, which was our health workforce management arm, shared services organization, and others. And this was all done via legislation called the Connected Care Act. Since then, we've also created a new Mental Health and Addiction Center of Excellence with the aim of bringing an agency approach or a provincial program approach to a sector that has historically been very diverse and disorganized. But just as Ontario Health was established, the pandemic hit, and quite overnight, we were faced with a brand new challenge and the very admittedly daunting task of starting to build this real integrated and de-siloed system that Duncan has always said we need, something we can be proud of. All of that was put on hold. And all of the machinery of this new super agency, which in those early days was really no more than a federation of its legacy agencies, was redirected to managing and mitigating the impact of this novel coronavirus on the healthcare system. Now, do you remember those early days and the scenes from places like Northern Italy and New York City and Los Angeles, where we watched the collapse of health systems, systems that became utterly unable to look after all the sick people who came all at once. And it was a terrifying time. We knew very little about this new pathogen. There was no vaccine. Society was locked down. Kids stopped going to school. All of the scheduled healthcare activity like surgeries and procedures and regular medical appointments were canceled and not rescheduled. This was indefinite, remember, at the time. Our communities and our neighborhoods were ghost towns. And all of us in this business we call healthcare, and this applies to the frontline folks, non-frontline people, and leaders alike, both clinical and non-clinical. We all had to react and adapt. We had to pivot from building and evolving a better system to mitigation and harm reduction. We had to go from aiming to deliver best care to delivering best possible care. We had to pivot from practicing and working in our usual comfort zones to practicing and working in places and in ways that were decidedly out of our comfort zones. From predictability to perpetual uncertainty. There was the specter of triage protocols, the shortages of personal protective equipment, the fear of bringing COVID home to our families. Blood, sweat, and tears. We watched a lot of people get sick. We watched a lot of people die. We watched a lot of people who needed regular non-COVID care have their care delayed and denied. We experienced moral distress and angst. We worked long, tough, and grueling schedules. Wave after wave after wave came and went with little time for recovery in between. But we also saw tremendous ingenuity and innovation. We saw barriers to change, things that we couldn't penetrate for years, simply evaporate when catastrophe would have been the result of the status quo. We saw widespread nobility and solidarity and goodness in people who were united in a kind of way that we never really saw before. And I would submit, we saw how system thinking, as opposed to siloed thinking, was the only way we could possibly get through this. So way back in wave one, we started recovery planning. And that was pretty optimistic, given that there were 7 more waves to come. An 8th one, I think, probably has just started this week, looking at the data this morning. But back in wave one, we started recovery planning. And when we started thinking about this conceptually, we imagined this restore bucket, a sustain bucket, but most importantly, this transform cross-cutting theme. Now, the restore and the sustain activities have been tough because we've had, as I say, at most, 2 or 3 months between COVID waves, and it's hard to recover from an attack that just keeps on coming. But I raise this in today's context because we knew, even in early planning, that this crisis was likely to provide an unprecedented opportunity to accelerate healthcare transformation. And that means ensuring, as many have said earlier today, that we don't let the crisis go to waste. Where can we accelerate healthcare transformation? Can we accelerate the integration agenda? How do we use these new regional structures? How do we use Ontario health teams? How do we partner in new ways? And can we use all of this disruption as a catalyst to finally tackle some age-old problems? In other words, it's not so much about what we want to recover from, but what we want to recover to. So, we're still very much in mitigation mode. These bubbles on the screen here are our latest focus for the fall as we anticipate managing a 1-2-3 punch of COVID, influenza, and RSV. You'll notice that these 5 things are very much about keeping the lights on and trying not to backslide on our recovery progress to date. There's not a lot of innovation here. This is about keeping the lights on. We're still managing hits to the system. We haven't even really properly begun to achieve the promise of what Ontario Health is meant to deliver. But I'd still like to reflect on a few experiences or files at Ontario Health over the last 18 months that I think show how we can use this adversity and disruption to serve the healthcare transformation agenda. And I'd like to suggest, perhaps a little bit optimistically, that some of this transformational work is already underway. So let me start with something we've been hearing about in the press a lot. And this is something that I've devoted a lot of attention to in my pre-Ontario Health career, and that is the surgical backlog. Before the pandemic, we called it the wait times problem. But now, in the context of the pandemic, the focus is on clearing the backlog. And I believe we're on the cusp of a fundamental transformation that will make some real progress on this 25-year-old problem. Now, this is a busy slide, and I'm going to take you through it because I think this is one of those pictures worth 1,000 words slides. So this is a look at the number of Ontarians waiting for an OR-based surgery in the dark blue. These are absolute numbers. So pre-pandemic, in 2019, over to the left on the graph, at any given time, there were about 200,000 people on a list for an OR-based surgical procedure. Fast forward to early 2022, about 3/4 of the way across the graph, and that list had grown to about 250,000 on the wait list for an OR-based surgical procedure. Now, I bet you thought that difference would have been much bigger, right? Because 200,000 pre-pandemic, 250,000 2 years into the pandemic, you probably believed that would be a lot higher. Now, the red on the graph are the patients amongst the blue who have waited longer than their target wait time. They've waited longer than the maximum recommended wait time, which has been assigned for their condition and specific to their procedure and triage category. And you can see that, not surprisingly, the proportion of those waiting who have waited too long has grown. And we call these the long waiters. And our recovery strategy is to strategically target those long waiters going forward. Now, this is not surprising because throughout the pandemic, we meticulously protected urgent and emergent surgeries who are not included on this graph. And we protected those urgent and emergent surgeries very, very successfully. And so if you needed a surgical procedure very quickly, if you had a very time-sensitive cancer, for example, the statistics are very clear that those procedures were protected. So that was the appropriate thing to do. I'm sure you would agree. But with surgical volumes down dramatically overall, the consequence of that protection is that people with lower acuity situations had to wait even longer than they normally would have. So if you were waiting for a hip or knee replacement, for example, you are more likely to be waiting 9 or 12 or 15 months instead of 3 or 6 months. And those folks are called the long waiters. Now, this is an updated version of the same graph, and it takes us right into present day, right into September. And it shows that over the summer, the absolute number of Ontarians on a surgical wait list has already fallen back down essentially to pre-pandemic levels, to about 200,000 people. And again, those are the blue bars. But the number of long waiters in the red has remained stubbornly high. The growth of long waiters in absolute numbers has leveled off, but long waiters now constitute fully half of all of those waiting. And in order to get those long waiters to follow that pink dotted line back down to pre-pandemic levels, we need to ensure, and this is what we've modeled, that about 40% of all surgeries going forward need to be done on the long waiters. And the bottom graph here shows how we're struggling with that. We're only doing about 30% long waiters overall right now, with just most recently some tangible improvements, as you can see at the very end of the graph where the numbers are starting to tick up a little bit. So I apologize for taking so long to explain this, but this really has been an aha moment, and it's what has led to what I think is going to be a huge transformational opportunity. So we spent the summer working with our ministry colleagues to fundamentally change the way that surgeries are funded. Those of you who are familiar with surgical funding, and the Queen's head of the Department of Surgery is here tonight, I'm pleased to say. Those of you familiar with surgical funding will know that some procedures are essentially line item funded, and others are funded through hospital global budgets. So the so-called QBP funding, quality-based procedures, was intended to shine a light on so-called priority procedures and strategically sought to achieve specific volume targets in those very specific procedures. That's the history, that's the way things used to be. But fundamentally, should it not be the case that every Ontarian on a surgical wait list, any surgical wait list, should aspire to have their surgery done within a reasonable, medically recommended wait time. Why should you be disadvantaged and left to the whims of a hospital global budget just because your particular surgical need happens not to have been included in one of these priority funding streams? And so this focus on the long waiters, which only came to a head because of the pandemic, the concept that waiting too long is the problem, has allowed us to direct new government investments to over 100 surgical procedures that have been historically funded through global budgets, not just the privileged few procedures. Now it's about whether you've been waiting too long for anything, rather than whether your procedure happens to be in an advantaged funding stream. If we're successful in maintaining this change, and if we can deliver on an ambitious target to get the percent long waiters back to pre-pandemic levels and below, we'll not only have recovered the surgical backlog, but we'll have gone a long way to make sure that everyone who needs surgery in Ontario for anything gets timely care. And again, waiting has never been the problem. Patients will tell you they don't mind waiting if they know that the wait is safe, if they have confidence in the integrity and the fairness of the triage system, and if they know that they haven't been forgotten while they're waiting and they'll get concurrent care while they're waiting for their surgical procedure. It is waiting inappropriately long that has always been the problem. So by clearly stating that this is our goal, by providing the data needed, and by changing the funding enablers in a fundamental way, the regions and subregions and individual hospitals can figure out the how. But this is the what, to Duncan's point again earlier today. And I'll point out that giving local champions the tools and the information they need, but letting them figure out what the ground game is really the way to achieve this goal. So make no mistake, we're on a mission to reduce the number of people who wait too long for surgery. That is the prime directive, and we will hold ourselves accountable for achieving this goal. So this is pandemic transformational opportunity number one, finally developing a plan with teeth, with the appropriate levers pulled to meaningfully address wait times for surgeries once and for all. Now, having to do things really quickly with high stakes has become part of the daily routine on this pandemic crisis management roller coaster. In pre-pandemic times, complex issues required complex solutions with multiple players. And as you all know, things like that take months and years to work through. But during the pandemic, we've all had to repeatedly problem solve on an extremely abbreviated timeline. And this is only possible through what we came to call the Team Ontario philosophy. And what we mean by that was multiple partners coming together, strong leadership, directive leadership, a sense of purpose and urgency, and a whole pile of trust, working multiple work streams in parallel rather than in series. Now, one good example of this intense cooperation has been our approach to new COVID therapeutics. There have been several important advances in treatment for COVID. A couple of them are shown here. Paxlovid was the first oral antiviral pill. It's actually two medications, but it's marketed as Paxlovid, has shown a major benefit, demonstrating an incredible 89% reduction in hospitalization for high-risk patients with COVID. And Evusheld, a monoclonal antibody indicated for high-risk, mainly immunocompromised people, folks with solid organ transplants, stem cell transplants, and some leukemias, for example, as a prophylactic or protective therapy. Now, Paxlovid really has been a game changer, and it required a cast of hundreds to make this widely available, from the procurement people who secured a large supply, to the science table folks who analyzed the data and developed clinical guidance, to the Ontario Health Ad Hoc team who figured out how to get it distributed widely so it could be available, to the clinical assessment centers who rapidly developed, with Ontario Health support, efficient workflows to receive possible COVID patients, test them, do drug reconciliation and meds management because there's so many drug-drug interactions with this medication, to the primary care community who really stood up and embraced this, and the community pharmacists who came forward to be part of the effort. And then tracking and monitoring all of this so that we can ensure that all regions have access and all of the pills that they need and with strong provincial oversight to really drive. And this is just one little small snapshot of the data generated that shows, in essence, tens of thousands of patients treated, thousands of hospitalizations prevented, a towering achievement that has made and continues to make a huge difference for so many Ontarians, and a huge benefit to our healthcare system as well, in that we've prevented thousands of inpatient bed days from COVID. And all of this was made possible by a Team Ontario approach between multiple teams from the Ministry, from Ontario Health, from the federal government, and the clinical communities who did the on-the-ground leadership. And without the clinical urgency, these processes would have taken months. The fact that it was stood up in 2 to 3 weeks just shows what can be done when we need to, and how a highly coordinated approach, like a real system, Duncan, can produce spectacular results. One of the things that really keeps me up at night are the sudden shortages of things that just seem to pop out of the blue. The beginning of the pandemic saw a huge shortage of personal protective equipment that you'll all remember very well, and none of us will ever forget that. But since then, it's been one thing after another. And most recently, we've seen a global shortage of IV contrast media, or dye, contrast dye, that's used in many radiographic tests like computed tomography, CT, and in interventional procedures like coronary angiograms, and a shortage of epidural catheters used primarily in obstetrics. Now, I could spend hours describing all the complex and massive efforts to mitigate these two issues alone, dealing with suppliers and vendors, developing clinical guidance for this very unique circumstance of limited supply, developing conservation strategies, the clinical change management piece alone, the communication strategies, the monitoring of and the distribution of and the sharing of supply between centers. All of this was a massive effort. But the point is, that massive effort produced results. And my point of all this is to say none of this would have been possible before the pandemic. The unprecedented cooperation between the agencies, the ministry, the clinical leadership, the supply chain folks, the communications professionals, the regional and hospital leaders, this was the secret sauce. Massive project, complex, but it delivered the results we needed and fast. We were literally on track to run out of IV contrast in Ontario, but we managed to reduce the burn rate without sacrificing or slowing the pace of procedures. And so far, there's been no clinical consequence from the epidural catheter shortage. And we've managed this largely by moving supply around between centers in a very careful way. Another example of a real Team Ontario effort was the huge number of inpatient transfers made in order to protect some hotspot hospitals from completely going underwater during the worst of the pandemic. Now, the impact of this was nothing less than disaster averting, and I am not prone to hyperbole. This is a bit busy, but boiled down to its essence, the purple line here shows COVID-related critical illness patients, in other words, patients with COVID who were sick enough to be in the ICU. And you can see at one point that they reached 900 in number at one point last year. And keep in mind, we only have about 2,000 ICU beds in the whole province. 900 of those beds were filled with COVID patients at one point. And then the light blue bars here showed how we used a formal IMS, an incident management system, to direct transfers of these patients from one center in another in order to avoid some places from becoming completely overwhelmed. At peak, we were moving 140 ICU patients per week from an overwhelmed hospital to a hospital with capacity. And locally, many of you will remember that Kingston Health Sciences Centre took many of these patients from Scarborough. Then, as the pressure next mounted on the non-critical care beds, so there was the ICU phase, and then the next big pressure was on the so-called med-surg beds later in the pandemic. And again, the IMS orchestrated transfers here as well to protect the hard-hit hospitals. And this required a keen eye on real-time analytics, modeling, COVID numbers, situational awareness, day to day. And with these data, the IMS did a lot of what they called proactive transfers. Transfers that averted an otherwise certain crisis, as opposed to responding in a rescue way, responding after the functional integrity of a hospital had broken down. And it was incredibly successful. Nearly 1,700 proactive transfers were completed, all safely done, between hospitals of patients in med-surg beds. And in a similar vein, alternate level of care patients, those folks who are not acutely ill but who find themselves in an acute care bed because there's nowhere else for them to go, we saw hospital-to-hospital transfers of these patients as well earlier in the pandemic, all to distribute capacity to maintain critical operations. Now, was any of this good? No, but this protected several very in-trouble hospitals from having to resort to making some very difficult decisions like invoking triage protocols where we would literally have to decide which patients get treated and which don't. So this, I think, has been a very important lesson in how working together and having a highly coordinated approach has really saved several hard-hit areas from being completely overwhelmed, and it undoubtedly saved many, many lives. But the key to success, again, was that Team Ontario approach. And in this case, it was not so much enhanced cooperation between agencies and organizations, although that was certainly there, so much as it was an enablement of a command and control structure. The IMS was given the authority to make these moves, but they only maintained that authority because hospital leadership respected the integrity of the process and because they were connected daily with Ontario Health senior executives who were able to deliver the policy and the funding levers necessary for success. So the key learnings we want to take forward to our future transformed state are the importance of leadership and a culture of trust earned through quiet competence and process excellence, excellence in systems management with central coordination and real-time decision support, and excellence in business processes that support excellent, transparent communications and real accountability. The Team Ontario vibe here was that, fundamentally, we were in a space where every single bed in every hospital in the province was seen as an asset available to every Ontarian, and that we were prepared to direct patient movement to avoid catastrophe. And without this, we undoubtedly would have seen some very tragic stories. Now, I mentioned earlier that one of our principles was to make decisions based on data. That is one of the founding principles of Ontario Health. And data are a tool, of course, in bringing a professional approach to the running of a healthcare system, helping us to move away from political influences and the personal biases that are held by even the most noble and sincere leaders. Now, Dawn told us today that Canada is rich in healthcare data, but we often only see health system performance data after the fact, leaving us with lots to ponder, but with little ability to course correct in real time. So we have an extraordinary data and analytics shop at Ontario Health. It's far from perfect, it's always improving, but one of the things that really makes a difference for senior decision makers are the dashboard-style figures that are generated daily, populated with an increasingly fulsome set of real-time data. And COVID made this necessary, but we need to carry this lesson forward. Real-time data make real-time decision-making possible, and it brings legitimacy to these decisions. And it brings confidence that we're doing the right things for the right reasons, and it protects us from our own biases. So here's just an example, again, not meant for every detail, but just to show you one of the dashboards. It's an at-a-glance look at how we're doing, rolled up at a very high level. Deeper inside each one of these are layers and layers of data cut in different ways, providing additional detail. We can cut by region, we can cut by sub-region, we can cut at the hospital level, but this is the helpful tool that can be customized for senior decision makers. So this particular dashboard shows COVID cases, test positivity, deaths, outbreaks, COVID inpatients, ICU patients, vaccination status of hospitalized patients, the med-surg bed situation, the ICU bed situation, and the pediatric bed situation. We can drill down by region, by community, and by hospital. And we have a dashboard for pretty much anything you'd want to see in COVID world, and collectively gives us an at-a-glance view of the directionality of key indicators to help inform the decisions that have to be made this month, this week, and today. Here's another quick what you need to know today kind of slide, kind of like a dashboard, a rolled up, at a glance look at what's happening across the system. So this one includes surgery, cancer screening, diagnostic imaging, the ALC situation, bed occupancy, home care, emergency department, and primary care with some basic commentary and key stats. So this is the third important lesson, data and dashboards. They seem, I know, a little cartoonish, but when they're done well, they really are helpful in helping senior decision makers make the right decisions. And we can't expect them to be data scientists or to understand the complexity of data, but dashboards bring to life what decision makers need to know. And they protect us, as I say, from our biases. They protect us from the loud voices. They protect us from political pressures. And they protect us from anecdote-driven decision making. So this is the third transformational opportunity, the organization of our rich data holdings in a way that helps decision makers' daily lives, information that helps senior leaders make the proper strategic decisions and helps regional and local leaders play the ground game in a way that they need to play it while maintaining fidelity to our common strategic goals. Managing COVID has helped us to do this better, and it's a lesson we need to carry forward into the post-pandemic period. Now let me pivot to equity, the fourth area where I see pandemic-accelerated opportunities for transformational change. Now, in fairness, driving for equitable health outcomes was one of the foundational raison d'etre for Ontario Health, but the pandemic has brought some lessons sharply into focus and should inspire us all to embrace a culture of relentless improvements. And that is going to require us to become comfortable with being uncomfortable. Now, we have an inequitable society, and that spills over into healthcare. Racialized people, first-generation immigrants, Indigenous people have worse health outcomes across the board, some as a result of social determinants of health, and some because of reduced access or reduced quality in the healthcare system itself. The pandemic has exacerbated these inequities, as crises always do. And there are other inequities too, north versus south, urban versus suburban versus rural, mental health and addictions versus everything else. We're really working hard to make the pursuit of equity our North Star at Ontario Health, and this has to begin with data. We're using FSA, or postal code data, to help guide our surgical recovery, and we're using these data as well to power our vaccination strategy, completely turning around horrible disparities in vaccination rates between areas where there are more white folks and areas where there are more racialized folks. And our data shop is moving rapidly to supply rich data to decision makers on where the disparities are, moving toward the use of race-based data to show where the gaps are. Now, I hasten to add that this work must be done extremely thoughtfully and carefully, and with the help of those with expertise, including experiential expertise. FSA data have limitations because they're not about individuals, and medicine is plagued with a long history of so-called racial correction based on the discredited notion that race is a biological rather than a social construct. These practices have led historically to things like adjustments of kidney function calculations based on race, for example, or routine use of higher radiation doses delivered to black folks to better penetrate their skin and bones to get a good X-ray picture. So this institutional racism is still deeply embedded in our healthcare culture and in our educational curricula, even today. And so race-based data collection, intended to serve the goal of better equity in our health outcomes, must navigate these layered and complex issues with great care and respect. Now, here's a real-world look at what happened with COVID vaccinations in Ontario. Now, this work was led by Homer Tian. It should have been no surprise that, for a whole host of reasons, Black communities in Ontario experienced a disproportionate impact from COVID. Low trust, vaccine hesitancy, and barriers going to mass vaccination clinics are among the reasons for this. So a group of organizations approached Ontario Health to form a Black Health Working Group to focus on an equitable response for Black communities, with fears that a simple standard provincial vaccination rollout would leave these communities behind. And together we were successful in prioritizing a number of neighborhoods in Toronto and Peel for a tailored, culturally specific vaccination rollout. And what that meant is that additional funding through the province's high priority community strategy would flow through Ontario Health Regions to support tailored vaccination efforts. So what you see here on this graph are blue dots showing prioritized neighborhoods in Toronto and pink dots showing prioritized neighborhoods in Peel. The gray dots are the neighborhoods that were not prioritized. So these are neighborhoods that had a very low proportion of Black folks. So starting in March, at the very beginning of the rollout, everybody was equally vaccinated, which was essentially low rates of vaccination. By mid-April, the expected disparities started to appear in these neighborhoods. And then targeted grassroots efforts allowed these neighborhoods to catch up and in some instances pull ahead of the non-prioritized neighborhoods in terms of vaccination rates. And by mid-May, the prioritized neighborhoods had kept pace or exceeded non-prioritized areas. So some key enablers made all the difference. Take the service to the people. Jane said this earlier, using models like mobile pop-ups and workplace temporary clinics and so on. Efforts need to be led by the communities themselves. Barriers need to come down. We need to be open to undocumented people. We need to eliminate online-only registration. We needed to expand hours to accommodate workers who couldn't miss work. None of this is rocket science. And culturally safe atmospheres. Now, at the start of April, the postal code M3N was the least vaccinated postal code in Toronto. And you can see here visually what happened to M3N over the next few weeks. So M3N is the darkest black dot that starts off in the bottom left. And it catches up over the 2 months to be in the middle of the pack, showing that it's possible to move the needle with tailored community-led interventions. We have a ton of work to do with health equity. Here's a brief look at one area of current focus, which is mammography screening as a function of ethnic diversity. Dark pink on this map means high screening rates, but these are in areas that have low ethnic diversity. And teal, the teal color, means that there's high ethnic diversity, but very low mammography screening rates. So what we want to see, according to that 9-color grid at the bottom, is dark pink, dark purple, and dark blue everywhere. High screening rates for all areas with no gradient based on ethnic diversity. We have similar data for colorectal cancer screening and for cervical cancer screening as well. So we often know what to do in small examples like the community-led vaccination clinics or the Black Screening Task Force work, but we don't necessarily sustain or scale it. But the keys to success are declaring a desire to reduce disparities, using socioeconomic data and then drive to get more individual level data for even more precision, understand the patient populations being poorly served, try to balance the local flexibility needed at that operational implementation level while still driving direction and expectations centrally, and then use the information and early success to inform smart policy and targeted investments with accountability built in to deliver. So accelerating this work on equity is a key priority, and it's been driven and enabled by some of the pandemic-induced worsening of these existing inequities. Alternate level of care. Well, what could be a hotter issue right now than ALC? These are patients, of course, who are in an acute care bed in hospital, even though they no longer require, or in some instances never did require, acute care services. Now, this has been an ongoing problem for many, many years, a chronic bottleneck impairing patient flow in and out of hospitals. But even more importantly, this is a quality of care issue. Patients who are designated ALC don't do well in hospitals. It is a toxic place for them to be, because acute care hospitals are not designed or staffed to meet the needs of people who need something other than a bed in a small room to sleep in and a chair beside a window to sit in all day. Now, no one disputes that ALC patients should not be in hospitals, but for many years now, we've seen ALC patients increase in number. Now, enter the pandemic, and suddenly the urgency to fix this problem once and for all is front and center. and the critical conversations between home and community care, long-term care, post-acute care, and transitional care sectors are happening in a way that we've not seen before. Now, as you can see, the ALC volumes continue to steadily increase, with about 2,000 patients now waiting for long-term care beds alone. And there are many additional people out in the community who are waiting for long-term care as well, many of whom will wind up in emergency departments if we can't deliver better support for them. So it's a big, very complex problem. But again, in keeping with the theme of transformational moments, we're now seeing the difficult conversations happening in a way that they've not happened before. We've seen unprecedented legislation that's been enacted, and other levers are being exercised. A big commitment to get these numbers down and keep them down. Now, how these directions are operationalized will be critical. There are legitimate concerns about how this will be done and how patients and their families will be treated and how they'll be affected. It will take a lot of very hard work to make sure that patients are safe and receive the kind of care they expect and deserve. Whatever you think of the government's plan, and there's no question that, good or bad or both, this is another transformational moment. A pandemic sharpened and exacerbated issue that has prompted a very specific, likely to be very impactful action. And make no mistake, these are uncomfortable conversations. There are still many unknowns. There are many passionate advocates on many sides. On the one side, we have a patient designated ALC who may be required to wait for their first choice long-term care facility in a place that isn't their first choice, a long-term care bed that they don't want to be in. That makes a lot of people very uncomfortable. On the other side, we have a patient who can't get their important surgery in a timely way because the hospital doesn't have capacity. So our job will be to ensure that this new direction on ALC disposition is operationalized in a compassionate, respectful, evidence-grounded, and clinically appropriate manner, and that is a tall order. But this is a transformational moment. And finally, the healthcare workforce, also known as health human resources. There's simply no way I can do this topic justice in a couple of slides, and you've heard a lot about this from speakers earlier in the day. But suffice it to say, this is a worldwide problem. Previous to the pandemic, it was posed as something we would need to address in the context of an aging population and other key demographic changes looming, like the number of people that we expect will be diagnosed with dementia in the coming years. But the pandemic has taken a slow-moving freight train and turned it into a speeding locomotive. The healthcare workforce crisis is no longer coming. The healthcare workforce crisis is here. And we're seeing this in emergency department closures. We're seeing it in sporadic closures of obstetrics coverage across the province. We're seeing it in stretched staffing ratios and overtime. We're seeing it in the unchecked rise of agency nursing. We're seeing it in vacancies, absenteeism, and attrition. We're seeing it in our inability to recover historical surgical run rates. And we're seeing it in the faces of our colleagues across all of the health professions who are burnt out and demoralized. We're seeing it in primary care, where fewer and fewer new grads are choosing to do comprehensive primary care, as Jane outlined so eloquently earlier, when they're done training. We see that, according to the Ontario College of Family Physicians, 1.8 million Ontarians are without a family doctor, and an additional 1.7 people have a primary care provider who's over the age of 65. Now, early on, the focus was on internationally educated nurses, and following a very successful partnership with the College of Nurses, we've seen over 1,000 internationally educated nurses deployed into practice. Now, this isn't nearly enough, of course, but every bit helps. Externship programs have seen some success. These have been some small early wins. We've stood up some dashboards so we can understand things like vacancies and absenteeism and distribution forecasting, but as Dawn pointed out earlier today, the data are not very good across all the health professions. And then working up a planned approach for these anticipated healthcare worker shortages. How will we mitigate these? This work is ongoing, and as you can imagine, there are no easy answers. Now, data are power, and as we have started to see the numbers collected weekly, we can see that all sectors and all regions are hurting, and it's made even worse by the impact of COVID itself on healthcare workers. Sick calls in every sector, from home care to long-term care to hospitals and across all professions, roughly parallels the wastewater trends, showing that the healthcare workforce gets sick with the rest of the community, and this, of course, takes them off work. And in this environment, if we have an absentee rate that goes even from 2 to 3%, that's destabilizing for many healthcare organizations and healthcare provider organizations. Our data show weekly assessments of absenteeism because of COVID, absenteeism in total, vacant positions, all by professional category and cut by regions and hospitals. And collectively, it paints a sobering picture. These data allow for local problem solving, for rapid intervention and issue escalation in coordination with home and community care and the ministries of long-term care and health. Now, the sightline to service provider organizations is challenging, but we can get an idea of what's going on with these metrics like missed visits in home care to help manage the pressures there. Our Health Force branch, the former Health Force Ontario, has very capably run, amongst many other things, a very successful emergency department physician locum program for many years, supplying emergency department physician locums to rural and remote places in Ontario. This is a graph that shows the number of open ED shifts that remain open 30 days in advance of the shift. And this has risen to historic levels. So imagine 250 uncovered emergency department shifts in rural and remote emergency departments just 30 days before the shift is to be worked. But our team has managed to fill every single one of those shifts but one during the whole pandemic. And so when emergency departments have had to close, it's been because of nursing shortages rather than physician shortages, which always used to be the threat. So I offer this example to show what can be done in the face of extreme pressure and with an organized and dedicated team. The healthcare workforce issue is not a new one. Our worries about the future supply of the right kind of professionals was a growing one before the pandemic. But as we all know, burnout and other pandemic-related factors has ushered a wave of workers leaving the system. And as I mentioned earlier, this is a worldwide phenomenon. Some issues related to this have seen some sharpening in this heightened environment. Things like pay equity. So personal support workers in hospitals, for example, make more money than personal support workers in home care. Scope of practice issues and turf. We all agree that regulated health professionals need to work at the top of their scope of practice, but this creates change management challenges and tends to create a lot of turf issues. Are there opportunities for more efficient models of care? New team-based models and several extender models were tested during the pandemic. Alternate providers, clinical externs, scribes, non-physician extenders, all have been a natural experiment during the pandemic and may actually provide a pipeline for healthcare workers in the future. Something of interest to many of you and to our dean in particular, how does training need to change? And Jane spoke to this earlier today. And can we assemble a cogent provincial strategy or even a national strategy? Health Canada has commissioned an assessment on health human resources that I'm pleased to be co-chairing, and it's anticipated that this assessment will form the basis of a national health workforce strategy, bringing federal levers into the toolbox. And we've seen some interesting local innovations during the pandemic. In Erie, St. Clair, for example, they identified a critical shortage of PSWs and decided to create a new program to serve their own community. So they took a systems approach with multiple partners, and this spring they graduated 200 new personal support workers. It's been immensely popular, and today they have one of the lowest PSW wait lists in the province. There are many other PSW training innovations as well, including an Earn As You Learn PSW training program for workers in the long-term care sector. So it's time for me to wrap up. I want to finish by acknowledging explicitly that what I've discussed today has been focused on learning lessons from the pandemic, and that many of the systems responses have been focused on mitigating immediate risks. But any talk on healthcare transformation would not be complete without an explicit acknowledgement that the healthcare system, as imperfect as it is only a minor component of the list of contributors to the health of Canadians. Fully 50% of our health is determined by things like whether we have a decent roof over our heads, whether we've had a good early childhood education, what our income is, whether we have nutritious food to eat, and whether we're in a privileged racial or gender group. Ontario health teams aim to do much of this transformational work by federating all of the health and social care supports required to look after a population of people. So when you move into a neighborhood, just like you would say, here's where my kids go to school, you'll be able to say, I've moved into a new neighborhood, this is where I get my health and social care. An integrated offering that aims to leave no one behind. So this might be what the Canadian healthcare system would look like if we had a system. A machine that's greater than the sum of its parts. All the pieces moving well, the interconnectedness of everything acknowledged and appreciated, funding following the patients, seamless transitions, no misaligned goals or objectives. The pandemic has brought many unwelcome blood, sweat, and tears, but it has many lessons to teach us if we choose to listen to them. We've seen how big system thinking can solve big problems, do big things, and help us tackle big, hairy, recalcitrant problems. Everyone is tired, everyone's exhausted, and to get peace, we sometimes feel that we just want to return to the psychological safety of the status quo. But we have to resist the temptation to go back to the way things were. We've been given what I believe is a once-in-a-generation chance to make some transformational changes in the way we work together to accomplish progress. We have the burning platform, we have the levers, funding models, data and analytics, OHTs, home and community care modernization, the Team Ontario philosophy, and accountability mechanisms with teeth. And COVID has jarred us into real action on big, long-standing issues like ALC, wait times, and the future of the healthcare workforce. So let's make the blood, sweat, and tears mean something. Let's capitalize on the opportunity that this disruption and adversity have brought to our lives and to the lives of our families and our friends and our neighbors and our patients and our clients and all of our fellow citizens. Let's all commit to build a real system of care that is truly worthy of Canadians' confidence and trust. Thank you.
Okay, so we do have time to take questions, and I think that there'll probably be a lot of questions out there. The way that we're going to operate this, and I think I see some hands back there already, I'm going to pass this microphone over. And there is a question at the back, and Chris, I'll let you take the podium. Yep.
Thank you very much, Dr. Simpson, for your interesting talk. My question here is, how well is the Canadian healthcare system prepared for the next pandemic? Because as I hear from you, blood, sweat, and tears, I'm in tears right now. Are we prepared? In other words, also, is the world prepared for the next pandemic?
It's a really important question, and I think Duncan alluded to this earlier today in his remarks that we had SARS-1 and nothing seemed more important at the time, and we said never again. And then about 6 months later, it was gone. Public health officials and infectious diseases specialists will say quite rightly, you know, we're heroes during times of crisis, and then we're completely forgotten and deprioritized, like from the top of the heap to the very bottom of the heap. So I think your question is a good one, and the honest answer, I think, is that system recovery is entirely focused on sort of recovering the deficits that have accrued, the care gap that has been accrued. But there's not a whole lot of talk about what does this mean for the next pandemic yet. We're still sort of in that crisis mitigation mode. But we will have missed an opportunity, I think, if we don't have that conversation. Now, what I will say is that the length of this pandemic, we're now 2.5 years into it versus SARS, which was much more circumscribed. I think a lot of new ways of doing things are hard baked into the system, that even if we do no more planning, we'd be better prepared next time, but not nearly enough, to your point. It's a great question.
Hi, now I know you're not responsible for provincial budgeting, but I'm a bean counter, so I'm going to ask this question anyhow. Those reforms you're referring about are going to take money, get rid of the surgery backlog to actually build a home care system, deal with the population aging, et cetera. The last two longer-term projections we've seen from the Ontario government on the fiscal front has healthcare spending growing at a lofty 2.1% per year. If and when inflation ever returns to 2% from its current 8%, that would just cover inflation. It wouldn't even cover population growth, never mind aging, and wouldn't cover any of these reforms. So I presume these things are costed out. Are these plans going to constantly break the provincial budget, or is the provincial budget going to constantly break your reform intentions?
Well, it's a good question. And, I certainly remember back in the days when we had, economic growth of like 6% per year, we could have conversations like, okay, 4% is going to go to acute care, or 4% is going to go to kind of building, a community-based system, and we'll use 2% in the acute care sector to kind of maintain, the basic inflationary increases. But I've been persuaded by you over the years that those days are probably not going to come back anytime soon, although I'm not sure that's an absolute certainty. But the really interesting phenomenon in this care gap is that there's a whole lot of upstream care that just hasn't happened. So I mentioned earlier that we have about 200,000 people on the wait list for surgeries. How can that possibly be that we're at the same number when we've done, so much less surgery over the course of the pandemic? Where are all these patients? And so there have been some savings, if you will, from care not delivered. And that's an awful way to have to put it. But we have not spent, we've spent more because of some inefficiencies that are inherent in living in a COVID crisis situation. But there's been a lot of historical rates of care that have not been delivered because there's been a fundamental disruption in the supply-demand dynamic in healthcare that I don't completely understand yet. So I don't think that's something to hang our hat on going forward. But I'm not seeing or hearing any signs that there are worries that the bank is going to be broken just yet. But I share your concern about medium and long-term sustainability of this. Am I talking a little bit like an economist, Don?
Dr. Simpson, thank you for your presentation and thank you for your work on all our behalf. I was very impressed with one of your last slides, which talked about the externalities which actually relate to rates of morbidity and mortality. And while I understand that Ontario Health has its terms of reference and its focus, and it's focused on the specifics which you elucidated so carefully, the truth of the matter is that if you did heat maps of Ontario as to where the COVID infection was the worst and where the level of morbidity and mortality was the worst, that would actually correspond to a heat map showing the poorest parts of our communities. True here in Kingston, true in Toronto, true right across the province. And while there's only so much that Health Ontario can do, I respect that, the bottom line is if the government as a whole does not address, to use your term, some upstream issues about reducing the level of poverty-created health trauma and the level of poverty-created early sickness and the related issues and the pathologies of poverty, then it strikes me that however well the outstanding representations and changes that you are speaking about proceed, we're still going to have that core fundamental problem not addressed. And so while, again, this is not within your purview, but be interested in your perspective, when we decide that recipients of ODSP, for example, can get by at another 5%, when the rate of food inflation is over 12%, and they're already not awash in excess cash as they survive, we know that many of those people are going to end up in emergency wards, and they're going to be ending up in our hospital system, in some sense frustrating the kind of measured care and balance which you folks are trying to achieve. So I'd be very interested, to the extent you're able, for you to reflect on what Ontario Health can do and say in a constructive way to facilitate that discussion across a province that still its government still wants to pay nurses 1% more a year.
I certainly share your views, and I would say that even before the pandemic, it was quite striking to look at some of these heat maps and see, for example, in Hamilton, 2 adjacent neighborhoods that had a life expectancy of 10 years difference sharing exactly the same healthcare system. So it's very humbling, I think, to know that whatever we do inside our healthcare system really is, for many people, a minor component of the health of their lives. So you don't have to talk about trying to achieve equity for very long until the conversation starts to go into that space. And I think that's where the OHTs are trying to go. And already we're talking a lot more about housing at Ontario Health than we ever did before. And you might say, well, that's out of your purview, but we see it as very much part of our mandate. And as the OHTs develop, I think, and we imagine, more of an amalgamation of health and social care in a construct that aims to deliver those as a package or as a federation of packages or an amalgam of packages for a distinct population. That's sort of the holy grail where we're trying to get. But I share your views on this very much. And for me, it's just humbling when I describe all of the huge mountains we have to climb in the healthcare world, recognizing that more impactful measures are probably a much easier lift. There's a guy named Gary Block in Toronto that used to talk about prescribing money. You know him well. And it's a bit of a tongue-in-cheek thing, but what he means is, all these folks who work a minimum wage job, they have income tax deducted at source, but they don't have the skills to do their income tax returns, and so they're missing out on this ability to get an income tax refund. And he would have a team, a family doctor would have a team helping people fill out their income tax forms so they can get, their income tax return. So he's prescribing money, in his view. And I thought it was a very clever metaphor, to demonstrate, some of the things that we can do. $600 in somebody's pocket is a whole lot more important for their health than many of the things that I could ever do for them as a cardiologist. So, appreciate that.
Other questions?
Thank you. I just had a question about one of your earlier slides. You talked about how the long wait times are going to go down in hospitals, and you said you're going to increase funding, but what is exactly Ontario's plan to decrease wait times? Is it hiring more doctors, doing more ICU beds? Are you increasing medical school enrollments? So there's no real concrete plan to decrease those wait times, and you can't really just throw money at the problem and see it go away, so there has to be more of a plan.
Yeah, I appreciate the question. If the question is about surgical wait times in particular, I think you're right that it's not really so much that more money is needed. It's that we need to really focus on making sure that the surgeries that are being done are the people who are waiting the longest. And I think to lay people, that may sound absurd that it doesn't work that way already. But the fact that we don't have centralized wait lists, we don't have eyes into every surgeon's wait list data, the fact that surgeons compete for OR time, the fact that one hospital may approach their priorities differently, the fact that government incents certain kind of procedures to be done whether patients need them or not. I'm speaking a little pejoratively just for effect, or hyperbolically just for effect, but you can see that it's not really a system approach. And so the sum total of all of that is that somebody may get their hip done at the 3-month mark instead of the 5-month mark, while somebody else, in my area, for example, is waiting for an ablation procedure for their cardiac arrhythmia for 3 years. So this approach sort of allows us to adjust the distribution of procedures so that the thing we're trying to accomplish is to make sure that everybody is done within a reasonable amount of time, rather than having advantage procedures where people are done very, very well, faster than needed even, while other people lag behind. But I think the other part of your question was, just waits in general, because even on a surgical journey, The wait to have your surgery done is just one part of it. You have to have seen a surgeon to begin with, and there's often a wait associated there. Before that, you had to have diagnostic testing to have your issue diagnosed. There's often wait times for that. Some people have even delays in getting into primary care. And then after surgery, getting rehabilitation services, there's often a long wait for that. So all of these waits are in series, and you're quite right to say that health human resources concerns have emerged as the biggest barrier to that. The wait times are ballooning out on all of those segments because there seem to be not enough people to provide the care in a timely way. So it's all connected, as they say.
Thank you for the talk, Dr. Simpson. I just want to go back to the beginning again. There's a statement you made that I find a bit interesting, how most patients wouldn't mind waiting if they know that they're going to get the care in the end. I find that difficult to believe. I think most people would rather get their care as soon as possible. And your plan of prioritizing those long wait patients will transfer the burden to those urgent now. So I just feel like the graph is going to shift in its population, but not the levels that it's at. So do you believe that prioritizing those long wait groups will actually solve the problem, or will it just change the population?
Well, I think there's kind of two populations of patients that are being served by surgical procedures. So there's the people that have emergent and urgent needs. So if you have appendicitis, nobody's going to make you wait for a month to get your appendix out. It's going to be done right away. If you have a time-sensitive cancer, there are very carefully calculated wait time targets where it has to be done by a certain period of time so as not to affect your prognosis. That goes without saying. It has to happen no matter what. And in fact, it's because we've been prioritizing those that we have long waiters on the things like hip and knee replacements and cataracts. So that's the first observation. But even for hips and knees and cataracts, sight restoration is very important to people. If you're a caregiver for an elderly spouse and you're having a hard time getting around because of chronic hip pain, you're not going to be able to be the caregiver for your spouse. Your spouse is going to, then be in trouble. It's very important to get these done in a timely way too. But there are well-established, evidence-based maximum recommended wait times that everybody generally agrees are both clinically acceptable and acceptable to patients. Now, I think you're quite right that if we had an unlimited resource environment, sure, I don't want to wait 3 months for my hip replacement if I can get it done in a month. That's for sure. But I think given the confines that we have, the first cut is let's make sure everybody gets it done in a clinically recommended wait time so that the prognosis isn't adversely affected by waiting. We haven't accomplished that yet, and that has to be the first stop. After that, I think if we want to build, the customer service aspect into this and say, okay, I'm going to do you even faster than what is, medically reasonable because, that serves your particular, want or desire or need, then we can do that. But I think we really first have to get long waiters who are by definition waiting in an unsafe way, unsafely long. That has to be the first cut. Well, there's a bit of an if you build it, they will come. And, one has to be a little bit careful about just sort of building infinite capacity because the demand will track the capacity. And when that happens, when there's an abundance of capacity, then appropriateness starts to go down. So there's probably a sweet spot there somewhere where we have enough capacity to deal with everybody in a reasonable amount of time that balances that sort of dynamism in the demand side of the equation. But what you say is basically the essence of wait times. We saw the opposite happen in the pandemic when the resources were restricted through no fault of anybody's because COVID was so huge. The demand, if you will, for non-COVID care went down, and we don't know where it went. We honestly don't know where it went. But there were fewer emergency room visits, there were fewer primary care visits, there were fewer surgeries done. And we only can presume that there's a bunch of people upstream who are undiagnosed, unscreened, unseen, and at some point they're going to re-enter the system, and this is going to declare itself, right, in some way. But we haven't seen that show up yet, 2.5 years in. It's absolutely baffling. But there's a very complex set of circumstances that contribute to what we kind of somewhat inelegantly call demand in healthcare. And it's very, very dynamic, and it's dramatically affected by the supply.
We have a question over here.
Thanks for the talk. So I'm a family doctor from BC, and I just started practicing in Ontario. One of the reasons is actually, I think the OHG is very auspicious plan for integration of care throughout the system. So, but surprisingly, speaking to a lot of physicians, they're ambivalent about the OHT. So I'm curious about your strategy in terms of the process around whether it's communication or persuading, whether there's any incentivization strategies to, kind of socialize this. And I mean, I've only spoken to, probably only double digits number of physicians, but just curious about the strategy.
So if I caught your question, it was what is being done to incentivize physicians in particular from participating in an OHT environment?
But I mean, it doesn't. Yeah, I think there's many levels. Whether it's communication, whether it's socialization, it might be incentivization. Just is there a strategy?
Yeah.
Really?
Well, it's a good and complex question. I think the major limitation, I think, to the kind of reform that's needed to really make OHTs the way of doing business on the doc side is the Physician Services Agreement, which still rewards volume rather than outcomes, whereas the OHTs will have presumably outcomes as their predominant deliverable to which they'll be held accountable as a group. So I think that's one thing. On the plus side, I think there's been a lot of generational change, and you'd be able to tell me more than I would know. But I think fewer and fewer young physicians are interested in being business people or entrepreneurs. They're looking for a turnkey operation where you can come in, you do your job. It's a rewarding job. You're working with a team of other professionals, and you can deliver meaningful, measurable results. And you can look at the work you've done collectively and said, look what we did. Look what we've done for this group of patients or this community. And I think that model is very appealing. But fundamentally, most of the OHTs are still nascent. Some are really very well advanced, but most of them are just entities on paper. They're a group of healthcare provider organizations that have gotten together and they said, we agree with a set of principles, but the governance hasn't been sorted out, the funding hasn't been sorted out. And what is going to incent healthcare workers to want to be there, apart from the promise of what it offers, has yet to be sorted out. So there's a lot of work to do on OHTs, even if we agree that it's the right way to go. I hope that answers your question.
So I think we have time for one last question. Is there one last question from the audience? Oh, we might have come to the end of the list. So at the back, I think we have one last question. I'll speak up. Thinking of the gray hair population in the long-term care patients, there's a lot of problems with that. So how is the healthcare system handling to look at these health
Yeah, when I was CMA president, one of the things I often said from the podium is that if we can figure out how to look after the care needs of our elders, then we'll have gone a long way to fixing what's wrong with the healthcare system. The demographics speak for themselves. The landscape today is one of multiple chronic diseases, whereas when our healthcare system was designed back in the 60s, the landscape was one of acute disease. You got sick, you went into the hospital, you got better, and you went home. But now the landscape is very different. It requires a team of healthcare professionals to do it well. And it requires an understanding of how all of these things intersect. And we want to do as much of this outside of kind of institutional kind of settings as possible, right? We don't necessarily want people to be in long-term care in the numbers that they are. We want them to be home. We don't want people to have to come into emergency departments for things that can be managed by their community team. And I have a lot of faith, actually, in the over 65 crowd because they're very smart, they're very vocal, and they have a lot of political power. So I think we're hearing more that this is what's expected, and politicians will listen to that. But my personal view is that when I think about things that need to be reformed in the healthcare system, the person I'm imagining in my head most of the time is an older adult and how they're experiencing care.
So I think we're going to draw the formal session to a close here. I think that everybody here will agree that not only have we had a rich discussion of a lot of the problems, the issues that we are facing, but we're starting to see a lot of solutions. We're seeing how the healthcare system is responding. We're getting a really good sense of just how quickly it can respond when it has to, and when the pressure is there. Our task now is to figure out how to turn that into action to address some of these more systemic issues. How do we go forward, and how do we move the healthcare system in the direction we want it to go? So I hope you'll all join me in thanking Dr. Simpson. And I believe we have a little gift to pass along, but I hope you'll all join us just outside in the lobby as we go forward. So, thanks so much. Thank you. Yep.